We'll go ahead and get started. Good evening. My name is Doug Hanto, and I am the co-chair of the Surgical Ethics Working Group at the Center for Bioethics at Harvard Medical School. Along with my co-chair, Dr. Teresa Williamson, a neurosurgeon at Massachusetts General Hospital. On behalf of the Surgical Ethics Working Group, I would like to welcome everyone to our 2025 Harvard Surgical Ethics Conference. Our first session this evening is ethical challenges in global surgery. We will host one more session on April 28th. Over 100 individuals will be attending from around the world, and we would like to thank you for getting up early, staying up late, and taking time off from work or leisure to join us this evening. I believe we have an exciting 2 hours ahead of us. I would like to review a few housekeeping items before I introduce our topic for this evening and our moderator. We would ask that all of the attendees submit questions at any time during any of the talks using the Q&A feature found in the Zoom meeting controls at the bottom of your screen. Selected questions will be discussed after the presentations. We will have all three talks before the panel discussion begins at the end of the three talks. If you have any technical issue, please use the chat feature to send a message to all panelists, and a staff member will help. Also, please continue the conversation online with hashtag HMSBioethics in your social media posts. If you are interested in other webinars, bioethics news, or HMS educational programs, please subscribe to the Center's biweekly newsletter at bioethics.hms.harvard.edu/subscribe. It's my pleasure to introduce this evening's moderator, Dr. John E. Meyer, MD, Jr., MD, who received his MD from Yale Medical School and trained in general and cardiothoracic surgery at the University of Minnesota. He has been a pediatric cardiac surgeon at Boston Children's Hospital for over 35 years. He is a professor of surgery at Harvard Medical School and the first Tommy Kaplan Chair in Cardiovascular Studies at Boston Children's Hospital. He is interested in health policy and has served as a Society of Thoracic Surgeons representative to the AMA Relative Value Update Committee and the STS Health Policy Workforce. Dr. Meyer is the past president of the STS, past chair of the STS Finance Committee, and continues to serve on the STS Health Policy Council and on the STS Standards and Ethics Committee. He will be introducing this evening's speakers and moderating our panel discussion. Dr. Meyer?
Thank you very much. Good evening to everyone. Thank you all for attending our session. It's my great pleasure to introduce the speakers tonight. And the general area is, as you all appreciate, is sort of, for lack of a better way of saying it, global surgery and a variety of ethical issues that arise as a consequence or in the context of this global surgery topic. So the first speaker tonight is actually still in training here in Boston at the Beth Israel Deaconess Medical Center. My apologies. Dr. Rashi Jhunjhunwala was born and raised in Portland, Oregon, is currently in her final year of general surgery training at the Beth Israel Deaconess. She also, during medical school, earned a Master's of Arts in Bioethics and Society at King's College London, where she investigated ethical justifications for prioritizing surgery on the path to universal health coverage. She also spent 3 years working with the program in global surgery and social change at Harvard Medical School on projects ranging from the economic and demographic impact of gun violence, trauma systems research, national surgical planning for country-level health systems, and social justice in global surgical access. She's been a delegate to and given talks at the World Health Assembly in Geneva, the Consortium of Universities for Global Health, and the United Nations General Assembly about barriers to surgical care. She plans to continue her work in global surgery as a trauma surgeon and advocate for health equity. She will be starting her fellowship in trauma acute care surgery and critical care at the University of New Mexico in August. Dr. Jhunjhunwala.
Thank you so much. I'm going to just share my screen here. All right. So I will get started. Thank you so much to Dr. Hanto, Dr. Meyer, and the Harvard Surgical Ethics Group. I have been an on and off member of the working group for a few years now, mostly off, just given my clinical schedule, but it's great to be able to talk about something that I care deeply about, which is the ethics involved in global surgery. So I'll go ahead and get started. So I know that people who are familiar with global health and global surgery have heard this moniker quite a few times, but in 2008, Dr. Paul Farmer and Dr. Jim Kim wrote a piece in the World Journal of Surgery in which they referred to surgery as the neglected stepchild of global health. And there are many reasons for this. Many of them are, fair enough, that surgery requires a lot of infrastructure, lots of consumables, and like serious supply chains. There are a lot of upfront costs to building a surgical system. There are often many places, not as many skilled providers to provide this type of care. And kind of most importantly, in my opinion, one of the most important kind of overall philosophical challenges is that surgery is kind of a nebulous concept, in that people have a hard time sometimes conceptualizing what exactly surgery is as a healthcare intervention, as opposed to, providing care for malaria or cholera or, filariasis. Lots of different infectious diseases are easier to kind of think about and conceptualize, whereas surgery is a little bit more challenging. So, that leads us to the question of what exactly is global surgery. And this is a question that seems a bit straightforward, but actually to me is a very challenging thing to define. I've changed what I think of as global surgery over the past 10 years. And my current working definition is thinking about access. And so to me, global surgery is facilitating and providing access to high quality and safe surgical care in a timely fashion anywhere in the world. So, in Boston, where I am now, I think it's probably one of the most highly resourced medical cities in the world, I would say. But then moving to New Mexico, where there's one level 1 trauma center in the whole state, issues of access become much more prominent. So, I think to me, global surgery means the ability to provide good, safe, high quality care, regardless of where the patient is located. So as we think about universal health coverage and the ways that the WHO and other institutions and countries and governments think about how their citizens and their residents pay for their health care, there are a lot of different frameworks that come about. And one of the things that I think about as one of kind of the most interesting things in applied ethics is how do we set priority, and how do we decide what types of things get priority in our thinking and in our world? So this is one framework, and I think a lot of us might be familiar with the idea of cost effectiveness, and this is something we think about a lot in terms of how cost effective is what we're doing, and how much money are we spending, and what are we gaining. So cost effectiveness, though there are actually data that show that surgery can be very cost effective, it depends on what the effectiveness is that you're looking at. But, initially surgery is something that doesn't really seem upfront like it's going to be cost effective, largely because it's really difficult, as I said, to measure the indirect or future effectiveness of a surgical intervention. There's lots of downstream effects that are really kind of hard to quantify. And then also, the other thing is that surgical interventions can often provide substantial financial risk protection to the patient. It costs a lot to get surgery, but it also can protect someone in the future from having financial risk. So, for example, congenital anomalies or trauma, or people who have obstructive complications, those are usually pretty highly correctable problems, or correctable with surgery, and they can affect people who are often young and have a lot of productivity ahead of them. And because of the problem that they have and that requires surgery, which is expensive, they are subject to a lot of financial risk. And so one of the things that is challenging about the use of the WHO's Making Fair Choices framework, which is on the path to universal health coverage, which is a framework that was published in 2014, their unacceptable trade-off that they mention, which is their second one they mention, is it's unacceptable to give high priority to very costly services, even if their coverage of those services will provide substantial financial risk protection when the health benefit is less compared to a less costly service. So, an example of this is on the right of the screen here, or my screen at least, you can see a box that is from the paper from the WHO framework. And here you'll see that, here, let me just click here. So malaria and congenital heart anomalies, they're both have a significant individual disease burden in terms of years of life lost. So actually congenital heart anomalies can lead to more years of life lost if not adequately corrected in a timely fashion. And then malaria as well. So it's much cheaper, though, to treat malaria and then to provide congenital heart surgery, as Dr. Mayer, I'm sure, is aware of. And so thus, under this framework, malaria is more highly prioritized than congenital heart surgery. And, I'm not kind of arguing that congenital heart surgery is more important than anything else, but it just is an example of how the focus on cost effectiveness without considering other things, such as the high burden of surgical disease in the world, effect on future earnings, and the amount of money it costs to actually undergo surgery, that might be, those are other things that could be prioritized and important in determining how we make these trade-offs and how we prioritize things. So moving on from 2014, so that was, the beginning of some kind of priority setting and frameworks that are being developed for thinking about surgery on a global scale in terms of health coverage. And then in 2015, that was kind of a big year for global surgery. The World Health Assembly in 2015, actually just under 10 years ago from now, adopted this resolution called Strengthening Emergency and Essential Surgical Care and Anesthesia as a Component of Universal Health Coverage. So this was an explicit kind of mandate from the WHA that emergency and essential surgical and anesthesia care was actually a critical component of universal health coverage. In the same year, actually, at the end of April of 2015, the Lancet Commission on Global Surgery was published. And this was like a huge endeavor undertaken by many, many partners across the world, looking into many different factors of surgical care and surgical burden of disease. And it was also kind of one of the first times there was a unified understanding of what exactly the burden of surgical disease is in the world. And from this, we get kind of one of the tongue-in-cheek famous taglines of global surgery, which is burned into my brain, that 4.8 billion, which is, that number is much bigger now, but in 2015, 4.8 billion people worldwide lack access to safe, affordable, and timely surgical care. And that's a huge number. And, when you think about safe, affordable, and timely, those are things that I think all to the understanding of access to healthcare, safe and effective surgical care. So in thinking about, again, more about how do we decide what's important? How do we get political priority for different health issues? So in 2007, Schiffman and Smith published this framework for thinking about political priority in global health or in healthcare policy. And in 2015, they published this manuscript, which looked at how that framework was applied to global surgery. And so there are 4 tenets of the framework are thinking about the actor power, which is, what's the leadership looking like? How is the community? Who is involved? Who are the people at the table, the stakeholders at hand of the issue? What are the ideas and the demands and the solutions that are being proposed? What's the global context and the policy context and the structure of global governance at the time that this issue is being presented? And then what are the characteristics themselves of the issue and how do those play into determining priority setting? So for global surgery in specific, Schiffman and Smith and Shawar in this paper, who's the first author, they kind of identified certain challenges. So they kind of, and sorry, just to be clear, this is a qualitative analysis. It was a stakeholder study of many different stakeholders across the context of global surgery. And they kind of came to the conclusion that there were not very many unifying leaders. There was a fragmented governance and epistemic community. In terms of ideas, there's not really a clear set of demands or solutions. And that it's hard, as I said, this is harking back to that nebulous concept of global surgery and what it means. What does surgery mean to people? And that's challenging as well. So not really getting that emotional connection there. In terms of political context, in 2000 to 2015, we had the Millennium Development Goals, and then in 2015, 16 onwards was the Sustainable Development Goals. And I don't think I guess they also argue that the surgical work community did not really take advantage of the Millennium Development Goals and plug their work into that context. And again, it's hard, for donors or people who are facilitating financing to really tie on to this idea of surgery and surgical healthcare, whether that means actually operations or, ICU care or things like that. It's hard to kind of conceptualize that. And so it's easier to donate money to HIV research or malaria research, but it's not really as easy to understand what global surgery is. And then this is something that the Lancet Commission really tackled, is the issue characteristics and the lack of data about surgical burden of disease, especially in low and middle income countries, and also the shortage of human resources. So in the last 10 years, there have been many different successes and wins in each of these 4 topic contents. So there have been many different stakeholders that have come on the scene. There's student groups like Incision, there's NGOs like Partners in Health, there's physician groups like the World Federation of the Society of Anesthesiologists, so getting the anesthesia folks on board, global governance systems like the United Nations, and advocacy groups like the G4 Alliance, as well as alliances between governments and governmental stakeholders as well. In terms of ideas, one of the other big outputs from the Lancet Commission was the concept of National Surgical Obstetric and Anesthesia Plan planning. And so that's kind of a framework, again, of how to develop and integrate surgical and obstetric and anesthesia in care into national health plans. And so this is a bit of a guideline that countries can use and adapt. And we've had some success with many different countries around the world working on developing these plans to include it in their national health policy. The Sustainable Development Goals, as I mentioned, we're starting to be a little bit more conscientious about aligning the surgical healthcare sphere with and seeing how they line up with the Sustainable Development Goals. And then the Lancet Commission also identified these 6 surgical indicators that health systems can use to kind of identify where they fall and what their gaps are in providing safe, affordable, and timely surgical care. So this is one example that I have for you of a project that I worked on alongside the Southern African Development Community, which is one of those kind of governmental and non-governmental stakeholder consortiums. And here you can see that financing and then stakeholder engagement and priority setting for surgery within health plans were kind of the biggest barriers that they identified in developing national surgical plans. So the priority setting piece and the frameworks on which upon which to build priority and identify which healthcare interventions are the ones that we're going to prioritize, that's missing. And I think that's where ethics really comes into it, because you have cost effectiveness, you have human rights, and you have to find a framework, an ethical framework that really speaks truly to the issue at hand and also is broadly applicable. So, we come to 2020 and the COVID-19 pandemic, obviously that affected everyone in the world. It's also a time of social injustice and kind of a lot of conversation about the global world order and neocolonialism. and the way that that plays into global health. And, with the murder of George Floyd here in the United States and the ensuing conversations from there, and how those spread all over the world, and also thinking about whose voice is driving the conversation. This is a manuscript published by some of my dear friends from the program in global surgery, thinking about how inequity in global surgery still persists in categories of these. So thinking about who kind of holds the microphone. So, the dominance of Western biomedicine and global surgery, and that the power really largely does remain in the global north. That's where research is being done. That's where the funding is coming from and going to. That's who has the kind of the larger voice in the conversation, despite the fact that many of these projects and the research is being done in the global south. So these are all kind of these concepts of how neocolonialism is applied to global health and global surgery specifically, and how we can kind of change that landscape, and how that can really play into the prioritization process. So in 2023, in response to kind of the COVID-19 pandemic primarily, the WHO passed another surgical healthcare resolution, and this is called colloquially the ECO resolution, and it's where they called for the integrated emergency, critical, and operative care for universal health coverage and protection from health emergencies. And so I think this is a really interesting concept, because before, in 2015, there was really the focus on national surgical obstetric and anesthesia care. And then now we're working on another reframe to kind of break down those silos of surgical care apart from emergency or critical care. And, we know from the pandemic and from our lives that those things are all really well integrated and interdependent. And so instead of seeing surgery as a silo in itself, even though it's something that is broader and more horizontal in its application rather than infectious disease or whatever, we see it, operative care and emergency care and emergency and critical care is kind of linked together. And so that brings me kind of to my my point and one of my pet projects here, which is the concept of the capability approach as an ethical and framework that potentially can be useful for thinking about these things and thinking about how do we prioritize surgical healthcare in different contexts. So this is a ethical framework proposed by Amartya Sen, who's an economist and philosopher. And the central tenet of this thought process is that we should, as a community, a global community, enable people to be and do what they have reason to value. And I think this is such an innately kind of intuitive concept, in that it speaks to each person and each community's individual values. And mine might be different than yours or whoever's, but as long as we are all able to achieve what we value in our lives, then we're doing something right. So Martha Nussbaum is another philosopher who also has been really integral in kind of instrumentalizing this concept, as well as many, many others. But there's this idea that there are certain central human capabilities that we, as humans, all need in order to be able to live a life that we value. And one of those is defined as the capability to be healthy. And my mentor from my master's program has really thought a lot about this, and how the capability to be healthy kind of almost underpins the rest of the human capabilities that we think about. As without health, whatever that means to you, health can look like different things also to different people, but without health, you can't really achieve the rest of your human capabilities. And one of the things that I think is really intuitive and helpful about this framework is that the criterion by which we define the capability to be healthy can be variable based on the context. So cost effectiveness is one thing, priority to the worst off, financial risk protection, and then other things like, the ability to care for others in your world. So maybe we prioritize people who are pregnant and being able to provide healthcare in that sense, so that they can then continue to care for their children and for their communities, or other workers in that they might be providing for their families, and being economically productive might be something that is also really critical to being able to provide value in their lives. And then the other thing is, the last thing I will say, I guess I'll say about this is that it's infinitely definable, and there are criteria that can be specified based, as I said, on context that can make this a really adaptable framework. And then through the defined set of criteria, perhaps healthcare interventions can be better prioritized to suit the communities that they serve. So that's kind of my food for thought here and my broad, quick overview of priority setting in global surgery, and I'm happy to take questions.
Okay, I think our format here is we're actually going to ask the questions to be submitted through the Q&A feature on the call, and I think we'll try to have everyone hopefully enter questions there, and then we'll try to deal with them at the conclusion of these three talks. So in an attempt to keep us moving, it's my pleasure now to introduce Dr. Barnabas Alayande. He's a specialist general surgeon, assistant professor of surgery, and co-chair of the Center for Equity in Global Surgery at the University of Global Health Equity. He has a background in medicine and surgery, theology, business, and global surgical care, and has been involved in surgical system strengthening in sub-Saharan Africa, the development and delivery of novel, equity-driven, contextualized surgical curricula at the undergraduate and postgraduate levels, and his research focuses on sub-Saharan African trauma care, surgical safety, and human factors, surgical education, improvisation with innovation, and the use of context-specific new surgical technologies. Dr. Alayande is going to address us on the topic of local brain drain or global progress, exploring the impact of outmigration on surgical advancements in low and middle income countries. Dr. Alayande.
Thank you so much, Dr. Meyer, and I'd like to appreciate Dr. Doug Hanto and the team for inviting me to be able to share some of these thoughts and lived experiences that I've had. Great. So I'll be talking on local brain drain versus global progress. I'm as has been mentioned, currently in Rwanda. But I wanted to point out that my origins are from Nigeria. This picture of us growing up, we're eating around one pot. You can see a mattress on the ground without a cover. My mom took this picture several years ago. We didn't have too much, but life happened, and then went into a primary school that I could not afford, supposed to have dropped out in fourth grade. But somehow or the other, I walked into the principal's office and said, look, I'm not ready to leave. What can be done? They paid half my school fees. That's to say that I have experience. And then I went to a medical school, solid medical school that was a WHO Center for Community-Based Education and Service, served at, did my housemanship internship, and then eventually ended up in a place where I was the only doctor with 19 health facilities in rural southeastern Nigeria. Not to say that this was the easiest place to be. I took a picture of our water source. It was literally a spring coming out of the ground, and I watched patients die a few minutes to the health facility for one reason or the other. Why am I saying this? I just wanted to make it clear that I have experienced both sides of the equation, seeing surgical work, clinical work in a low middle income country context, a low income country context, and then having the privilege and the opportunity to be at the Harvard Medical School for some time, currently now in Rwanda at the University of Global Health Equity. I just put these thoughts there again to show that there is some context in terms of my reflexivity and the ethical tensions I'll be talking to you about. I have experienced in a number of different ways, fellowships on 3 different continents, and then choosing to still stay in Africa. Let's start talking about the challenges of access to surgical healthcare. Rashi has established a good number of them, and we know that we need more surgeries all across the globe. but do we really need them all across the globe? Yes, and we should also consider that there are places where they are needed more, right? And only 6% of these surgeries that happen around the world occur in the poorest of countries where 1/3 of the population lives. I just put here the global total of surgeries that are being performed, and then you can actually look at where they are performed. So we have a goal based on the Lancet Commission of 5,000 procedures per 100,000. And the key thing, the key issue that meets those goals, moves us to meet those goals, is the workforce, right? We're looking at specialist surgical workforce, non-specialist surgical workforce. They are getting the procedures done. They are the ones that make 2-hour access, as controversial as that indicator is, they're the ones that make that a possibility. So 3 of the 6 Lancet Commission indicators of access to surgical care, they rise and fall on this workforce. Now, where is the workforce across the world? 3 to 4% of the health workforce, for instance, I'm speaking concerning Africa, is in Africa, where we have 24% of the global burden of disease. And there's a shortage of this workforce, right? We have a shortage of 7.2 million a few years ago, rising to 12.9 million by 2035. Now, why am I saying this again? Let's see, where is this workforce? I put some countries here: Ethiopia, the number of surgeons they have per 100,000, Gambia, Uganda, etc. And then you see the US here, where we're almost at 70, if not at, in terms of the SAO, the surgeons, especially surgeons, anesthesiologists, obstetricians. And if you add in nurses, I mean, it goes a long way. All this to say that there are needs across the world, but there are greater needs in certain places. And this issue of inequity can be looked at in terms of what's happening by income bracket of countries, where surgical procedures have been done by market share, what is going on in terms of urban and rural, even within countries. So we start to think, as we look at these statistics, about the framework of distributive justice. Are we talking equity versus equality? Are we talking needs-based allocation? What is the moral obligation of wealthier nations, right? So yes, there's a need for surgical care across the world, but I think that we shouldn't just make these blanket statements and really think in depth and start to grapple with this issue of distributive justice. So these are just random write-ups that we can find about Africa's loss, their gain, how the US and UK benefit from medical brain drain. There's a beautiful paper by Duvivier and colleagues talking about a comparison of physician immigration from Africa to the US between 2005 and 2015. And then another good paper, which we may talk about here, about measuring the migration of surgical specialists. And so they looked at data, the authors looked at data from 48 high-income countries, looked at low-income countries. They checked the granular medical qualification of all surgeons. Where did they get it from, etc., and looked at low-income country surgeons and found overall, this is the summary, that countries with the lowest remaining density of surgical specialists were also the countries from which the largest proportion of graduates were now working in high-income countries. Yeah, so statistically significant that more people are working in high-income countries from countries which have the lowest number of surgical specialists. Now, what does this imply? And this tide is not stemming, right? So from West Africa, 50% of doctors in Nigeria and intending to emigrate. We're seeing that you're putting out applications for residency and you're not getting people who are coming because they're writing the PLABs, they're writing the USMLEs, they're looking to leave. And that's why they're going. The same story for nurses. But this concept of outmigration, where is it happening? It depends on where you are. It's about your gaze and your pose. So if you look at Africa, there's kind of like a line down the center, and to the east, brain drain is kind of like a myth, particularly within surgical circles. We looked at this paper. Seeing this paper, I wanted to find out, is this really true? And then we did a follow-up last year, and truly you find that there is a lot of retention, currently at about 97% on the continent for surgeons that are trained in East, Central, Southern Africa, versus 80 some percent in country, 92% in the region, versus West Africa, where the emigration is in droves. So where are people going? Just to set the ground, where exactly are people living to? So there's a lot of circular motion, right? People are living from one end to the other. But this is what the data tells us about migration patterns. People are going to where there's cultural congruence, where their linguistic factors are favorable, where there's historical colonial relationships, language similarities, visa accessibility, easy integration into the healthcare system, and then there's social bonds. There's a Nigerian proverb that says a man doesn't go far from where his corn is roasting. So somehow those migration patterns, we did another study within the COSEXA region, and actually mapped where individuals were going, right? And so there's some secular movement, but this holds true that there are certain things that drive this migration. Now, so what? So what? Arguably, we can say that surgical mortality in Africa, which is 2 to 3 times the global average, that 1 in 5 patients develop complications at African hospitals and die, compared to 1 in 20 in HICs. C-section maternal mortality rates are up. Trauma patients' mortality. All this may be related to the quantity and the quality of the workforce, and so when workforce emigrates, right, outmigrates, there are arguable effects about impacts on less service providers on the ground. There's a lot of sweat. I've seen people, actually was in systems where people would leave about every 2 weeks, right? And you have fewer service providers on the ground. You have a challenge in terms of your work. We had issues of public resources wasted on education. For instance, I paid $20 per year for my medical education, $20. And that's me paying. But you know what? Somebody else was paying. The government was paying my fees. This was highly subsidized federal system. And so what happens when individuals leave the system? Their essential public resources wasted on education, less tax revenue, diminishing pools of teachers, declining quality of institutions, lost opportunities for political change. Now, looking at all this, are there any benefits? Yes, some people would say there are remittances from immigrants. Does this reduce poverty? Does this encourage development? We know that they're sent home in limited amounts. They can't compensate public investments in, for instance, medical training. And looking at the data, countries most hit by the health workforce crisis have comparatively low share of remittances. Same thing in terms of source countries. Are they benefiting from returning migrants? Some people have tried to do that, but few migrants return. And return of talent programs that attract doctors and nurses to the country of origin, they largely fail or come at a very high cost. It's limited to few migrants. So I'll read this from the American Medical Association. It said the entry of approximately 6,000 international medical graduates into the United States every year contributes a few $1 billion to the US economy, which is equal to the output of 50 additional medical schools without any cost to the taxpayer. Right? So what are the ethics of bilateral or multilateral compensation models? Do we even see that? Are countries paid for the health workers that immigrate? So Kenya is attempting to try that or to start that. And let's see. I wrote a piece, Through the Eyes of Freedom, around the time of COVID, when planes were flying into a particular West African country and actually offering reduced, in fact, without a visa, they were getting people to go charter flights and saying, come over to this high-income country context, come and work. We need doctors. So they were stopped at the airport. At some point, 58 stopped at the airport, but all they did was take a road trip to Ghana, and then they flew from there. About 2 weeks from there, or the very next week, and this made headlines. I will leave the thoughts there so that we can look at why do people go and what are the ethics around that. So there are push factors. And these you know what they are: high burden of disease, shortage of care, work is much. There's so much that's going on. These are just snapshots looking at the Resident Doctors Association in Nigeria. There's strikes here and there. People are operating with torchlights, doing surgeries with flashlights. Where we've been. So the environment is sometimes hostile. Right, poor working conditions, low remuneration, heavy workload, burnout, lack of research. So that brings us the ethics framework of structural violence. Sometimes we blame people for leaving. Leaving sometimes is a survival strategy, not a betrayal. In fact, in my language, when people leave, they call it jakba. What that means is something has been holding you down, and then you are able to break out from it. And that speaks to something, that there's some form of structural value. Look at this quote that's on the premium time. So he said, I left the country almost 6 years. Before I left, I was struggling to get a good job in spite of spending almost 9 years in school without failing medical school. I left because it was becoming frustrating and the opportunity presented itself. Some colleagues took the opportunity while some decided to stay back. Some of those who stayed back are also leaving. The situation is getting worse. So there is some kind of structural violence, which refers to social structures, economic, political, legal, cultural, that systematically harm, disadvantage individuals and populations. Sometimes it's not a personal choice when surgeons or surgical providers leave. And so some systems that make it impossible for African surgeons to thrive at home. It means that their migration is not an ethical failure, but a consequence of structural injustice. So one of my friends said this. He said, the slave ships are back, but this time with padded cabins. Tough statement, but he was speaking about the pull factors, right? This time there's a pull. And what do we mean? You get fellowships or training. I know several people who went for specific named fellowships, never came back. Like it was just like a pathway. Hey, go for this. And it was just like a pathway there. Preceptorship to recruit. Sometimes there's recruitment. Their entire hotels that are taken and for weekends, and people just come with flyers and folders. People come in and they're recruited. They're given a smooth move. So sometimes it's even seniors, people who have walked the path before, that just make everything easy for these individuals. So how is recruitment being done for people who are emigrating from low-income surgical systems, right? We have to think about the ethics of this. I will leave these thoughts for time. So ethical migration, in terms of pull factors, ethical migration is the idea that the movement of health professionals from low to high income countries should happen in a way that, one, respects individual rights to move, grow, thrive. Two, it protects the health systems in resource limited settings. Three, it ensures fairness in training, recruitment, and compensation, and then promotes some kind of reciprocity between sending and receiving countries. So it respects autonomy, justice, accountability, reciprocity, and then system protection. And while this is codified in many ways by the WHO, I'm not sure that this is actually what the world works, or how the world works. And then, so other than push factors, pull factors, there are stick factors. People just stay because of patriotism, sense of duty, bonds. Sometimes they're like, you have to stay for the next 5 years. Rwanda has some public service agreement for about 4 years following residency. So cultural ties, family ties, strong connections, national incentives, mentorship, etc. All that can cause an individual to stay. But again, what is good for many? If we look at the framework of consequentialism, utilitarianism, what is the right action that produces the greatest good for the greatest number? Some people would say stay, but it might not be. Right? It might be that if this person leaves, he's able to help his family, he's able to, eventually come back to contribute. So that's an issue. Or are we dealing with deontology? Neither lens, or that this is duty-based ethics, neither lens offers any easy actions. So looking at the COSEXA region, one of the questions I kept asking is, why are people staying in East Africa? Why are people leaving in West Africa? What's going on? Right? So we looked at this issue and we saw being in surgical leadership, working in public hospitals, training in rural centers caused people to stay because they are embedded within the communities, and they were grounded. And so it kind of strengthened their ethic sense of deontology. This is my community. I'm married in here. I'm stuck in here. So that's the idea, but we still need to explore this further. And so we think about the ethics framework of dual obligations. You have one to your home country, you have to yourself and to your family, right? So these are the tensions that we feel here. Now, somebody, Prof. Chris Bode, this is a quote from him in the Guardian newspaper. He just said about how, and I see it as a common sense framework, right, an ethics framing. About half of Nigeria's estimated 72,000 registered doctors practice abroad in 2020, and I'm sure that number has risen since. And he says there are four concerns. I took the liberty to number them. We don't have enough workers in the vital sector. We make huge investments to produce them. Richer nations simply harvest these workers free from our system, and we seem powerless to stop the trend. Note that we seem powerless to stop the trend. I mean, it's individual choice, right? So again, is this unethical? And there are many arguments to that effect. What are the ethics issues raised? Right to migrate versus right to health? Are we building capacity truly when we train people in different contexts? Or are we extracting talent? Are we training people for export, right? Just training them and just letting them go from a needs perspective. What is the colonial legacy of medical education that favored export? Right? What is global responsibility versus national burden? Are we dealing with local investment for global benefit, or should local investment truly be for local benefit? And then what are we doing? Are these aggregate individual choices, or are we looking at societal benefits or effects? And what's the distribution of the benefit and burden? So I think one perspective would be to say medical brain drain, surgical brain drain is unethical because the underlying causes are unjust, is a symptom of underlying global injustice in those countries where there are push factors, solid push factors from them. And then we could look at it as a violation of human rights, because the right to health care is impacted when a country loses its health workforce. So health is a special good. Now, again, there are no easy answers here, but I think that there needs to be more global accompaniment, more of what I would call reparative aid. A lot of things we think are aid today are actually taken from these countries, right? And so what we're looking at and thinking, oh, this is just aid, I think it's some kind of reparation. How do we enforce this? Are we allowed to say you cannot emigrate, you cannot move out? And then what is the wage gap that needs to be closed? So we have to think a lot about these issues because it does affect many of the spaces within global surgery. Currently, the thoughts are around some fluidity of the surgical, that's what we would call brain circulation, that people can go somewhere else and then bring back benefit rather than thinking brain drain or brain gain. Could there be some more emphasis on this kind of circulation? So those are my thoughts. I'm happy for us to have questions and further discussion along this. But again, as somebody who has experienced this conflict and this tension, opportunities to work here, opportunities to work there, does one really still need to stay on the continent? For why? And looking at it experientially within these frameworks, I think that this is an interesting conversation and also a deep one. Over. Thank you so much. Over.
Great. Thank you very much. I hope everyone will make use of the question and answer feature here for this because we will address the questions, as many as we can, that are submitted via that mechanism. So we will have that open discussion after our final talk. The talk is by Dr. Brian Earp, who's Associate Professor of Biomedical Ethics, by courtesy, Associate Professor of Philosophy and of Psychology at the National University of Singapore in Singapore. and a research associate of the Uehiro Oxford Institute of the University of Oxford in England. Brian's also Associate Director of the Yale Hastings Program in Ethics and Health Policy at Yale University and the Hastings Center. So Dr. Earp is going to discuss with us the effects of child genital modification. When is cutting or surgery permissible? Dr. Earp, thank you.
Thank you, John, for that nice introduction, and Doug as well for the invitation. Let me just pull up my slides here. I've made an adjustment to the title from the early draft, which John just read out. So it says genital modifications in minors, global and local practices in ethics and law. And so I'm going to be talking about a distance of travel, not from sending surgeries out from the global north to countries in the global south, but rather how surgeries elsewhere in the world can come to affect local politics and vice versa. And I'll be focusing on some contemporary debates in the United States that are influenced by international and global ethics conversations. So let me jump right in and give that perspective. I don't have any disclosures to share, but I have a couple of objectives, which I hope to accomplish in the next 20 minutes. I guess I'll start my timer here. I hope to leave you up to date with at least an outline sense of the latest ethical and legal debates around medicalized genital procedures, which will include surgeries, properly so called, but also some cultural practices which involve genital modification. And as I said, I'll be trying to transcend a global local boundary, but also looking across cultures, across sex characteristics, and across gender. And this will involve the discussion of highly politicized and polarized topics. And so we'll try to handle these as sensitively as we can, and then make sure we have time in the Q&A to work through some of the details and the difficulties. So I hope to leave you with some key concepts and arguments that you can use to, as I say, sensitively navigate these ongoing challenges and disagreements in this very fraught area. So I'll start with some immediate context, which will be familiar to many, at least in the United States, but probably beyond that context, which is a series of executive orders that have come from the White House and the new administration. And so you'll see here this very inflammatory language. The title of this executive order is Protecting Children from Chemical and Surgical Mutilation. Now, what this is really referring to is a set of surgical and hormonal interventions which are designed for healthcare services for transgender and gender diverse youth, commonly called gender affirming care. But you'll notice that the pointed use of this term mutilation in the executive order, which actually does have a role in US law, but it has historically been exclusively associated with a set of practices which the World Health Organization somewhat controversially defines as female genital mutilation. And this is considered to be a foreign practice to US culture associated with some immigrant groups. And so Trump has actually had a relationship to the so-called anti-FGM law in the United States, because one of the final acts of his last administration was to sign into law a particularly restrictive ban on what's, again, defined as female genital mutilation. And here definitions really matter, because we have to ask ourselves what falls under the strict legal definition and not only rely on stereotypes we may have from certain discourses about what we think people in other cultures or other countries are doing. So let me be very specific about the definition of the law. And as a reminder, this was one of the final laws signed in at the end of Trump's previous term. And now this language of mutilation is being revived and applied to another set of practices that are, of course, also politically contested in the current discourse. So the US law, which follows the WHO definition, characterizes as mutilation any cutting or surgery of the vulva, no matter how slight or severe, of an under 18-year-old, just insofar as it's not considered necessary for the health of the person. Now, this is not strictly defined what that means, but there's an implicit notion here of medical necessity. If it isn't medically necessary, then purportedly any cutting or surgery of the vulva of a person who's under the age of 18 years, regardless of parental consent or proxy permission, is considered to be mutilation. Now, in reality, this is applied in a highly selective manner. This is not applied according to the facial definition. It's applied exclusively to practices associated with minority immigrant groups. but we'll need to pay attention to that thread as we go through the rest of the talk. So I just want to highlight that mutilation here is not defined in terms of harmfulness or invasiveness or alleged destruction of certain functions. Rather, it's defined in terms of medical necessity and a lack of consent, operationalized here as the legal notion of being under the age of 18, so the legal capacity to consent. This law explicitly excludes parental proxy consent. So it says, even if the parents believe that this ritual practice is in the best interest of the child, for example, for purposes of community integration or what have you, that shall not be an excuse to the crime. Parental judgments of best interest are not considered admissible. The law also, in its current form, explicitly mentions so-called medicalized ritual nicking of the vulva, which is a type of cultural practice that's been medicalized, that's common in parts of South and Southeast Asia, where I now live, in Singapore, for example, but also in Malaysia and Sri Lanka and parts of Thailand, for example. And finally, the law is explicit that there shall be no religious excuse either. So even if the parents and perhaps the doctor, if the doctor is also a member of the community, believes that this ritual nicking is explicitly required by the religion, in this case, some sects of Islam argue that the practice is required, that shall not be an excuse. And so the practice will still be criminal. Now, I just want to be clear that there has been a law against so-called FGM since 1996 in the United States. The 2021 Act was signed into law as Public Law number 116309. You can see in the bottom right there. This was an amendment to the 1996 Act. It was an update on that earlier language. Now, why did the law have to be updated? Well, because it was struck down. Many people are not aware of this context, but in November of 2018, the federal ban in the United States on what's called FGM was ruled unconstitutional by a judge. And this was a decision that was based upon a case concerning this ritual nicking practice, which I've just alluded to. So that's the 1996 law that was struck down and then reinstated by Trump at the end of the term. Just a few months later, you see that the US Justice Department declines to defend its own law against what's here being described as female circumcision. Now, this is the same newspaper, it's the New York Times. Just a few months later, there's a change in language. And I want us to be sensitive to language. One question we should ask is, who gets to label whose practice as what? And what are the politics and the implicit value assumptions behind those labeling practices and the power dynamics behind those labeling privileges? So let me back up and provide now the deeper context. I started by jumping into the immediate context of political turmoil, executive orders coming out of the White House. But let me provide some broader perspective here. Why was that FGM law struck down? What's the broader context? And then finally, I'll be turning to normative, substantive, ethical questions. I want us to try to consider together as a group, when should genital cutting or surgery of minors be allowed? And here's some rough possibilities. You might think that these seem ethically relevant in terms of answering that question. So you might think if the parents give permission, that might be sufficient or might be necessary as a condition. You might think if the child themselves somehow consents or assents in an age-appropriate way, if that's possible. You might think that the intervention needs to be medically necessary. So it might not just be any procedure to which the parent or the child consents. One example I'm going to discuss is labiaplasty, which is increasingly performed on teenage girls. Probably not medically necessary on strict definitions of that term, but the teenage girls assent, the parents consent, and the surgery is performed. And in fact, as I'll suggest, this is strictly speaking in tension with the FGM law. And so this is creating some legal tensions that need to be addressed. Another consideration is whether the ethics of genital modification should in any way depend on the child's sex or gender. Does it matter if it's a boy or a girl? Does it matter if it's a child with intersex traits or congenital variations of sex characteristics or differences of sex development? The language here is fraught. Does it matter if the child identifies as trans or as non-trans? Does it matter if, in the case of a cultural practice, it's a majority cultural practice in the United States or elsewhere, or whether it's a minority cultural practice associated with immigrant groups? Or should the same rule, whatever it is, apply to everyone? And my take-home lesson is going to be very simply that whatever the ethics of genital modification, cutting, alteration, or surgery in minors are, the same rule has to apply equally to people, irrespective of their sex characteristics and irrespective of the immigration status of their parents or other such features. So here's the case in question that led to the striking down of the 1996 law. It concerned primarily this woman, Dr. Jhunjhunwala Nagarwala, who was trained at Johns Hopkins University, a very respected member of her community, which is the Dawoodi Bohra community, which is a Shia Muslim sect, primarily based in India and Pakistan, but with immigrant communities all over the world, including in Detroit, Michigan, where this particular case took place. Now, what's striking about this is that Dr. Nagarwala was accused of having performed FGM, not in the way that is typically held up in Western media, which tends to prioritize shocking images of what's imagined to occur in African villages, primarily. Rather, this was done in a modern clinical setting by a US-trained physician who nevertheless had religious convictions shared with other members of her community, and the parents requested that this ritual nicking procedure be done in accordance with their religious faith. Now, the Bohra practice, what's one of the words that is used is khatna in Arabic, which is an Arabic term, which means circumcision. And it's a gender-neutral term, so it applies both to the practice that's done on boys in this community and to the practice done on girls, in both cases with explicit religious reasons being cited as the justification for the practice, albeit in this case it's done in a medicalized way. I want to just flag that this is a general pattern. So any community, virtually any community, there may be one exception among the Hadza of Tanzania, but virtually any community that practices female genital cutting for ritualistic purposes also practices male genital cutting. So there are no communities that, as it were, single out girls for a ritual practice. But there are many communities that only find the cutting of male genitalia to be normative. For example, the United States. The United States has a birth custom of circumcision that's normative in this culture, whereas the cutting of girls' genitalia is considered to be abhorrent and is, of course, federally prohibited. The final important point here is that depending on the community, either the practice for the boys or the practice for the girls is more invasive. There's a very wide range of what's done in terms of technical interventions into the genitalia. And in the case of the Dawoodi Bohra, this pattern plays out, where the practice for girls is less invasive than the one for males, but only the female operation is regarded as criminal, even though girls are being initiated into the religion, as it were, on equal footing to the boys. The idea is they too deserve to be circumcised, not just the boys. So let me dig into that point here by referring to the work of the anthropologist Richard Schrader, a colleague of mine. Schrader writes, among some Muslim groups, including the Bohra, there's what he describes as a gender-inclusive version of the Jewish Abrahamic covenant. Not only the boys, but also the girls are circumcised. The procedure for girls amounts to a nick, abrasion, a piercing, or small cut restricted to the female foreskin or prepuce. This is the analogous tissue to the male prepuce. The custom is less invasive than a typical male circumcision, as routinely and legally performed by both Jews and Muslims, including in the same families where the girls were alleged to have been cut. And his argument is, if the practice is legal for the gander, why should it be banned for the goose? So he's here referring to basically equal protection requirements of the US Constitution. We have to have the same rule for boys as for girls with respect to ritualistic genital cutting, whether medicalized or not. So what exactly happened in the federal ruling? Well, as mentioned previously, the law was ruled unconstitutional. This was the federal judge, Bernard Friedman, who gave the ruling. And he made a striking argument. He struck down the law on jurisdictional grounds rather than equal protection grounds. So he said, the act in question, namely the medicalized ritual nicking that was alleged to have occurred in the clinic of Jhunjhunwala Nagarwala, constitutes what he describes as local criminal activity. He says, in essence, this practice is a physical assault. So a surgery is prima facie an assault, and it only becomes legally tolerable if it's either medically necessary or appropriately consented to. If it's neither medically necessary nor appropriately consented to, then it just remains an assault, is the argument here. And he says, if something's local criminal activity, it has to be handled locally by the states. You can't have a federal law that mandates the same types of penalty across all the states unless something like interstate commerce is invoked, which it wasn't in the 1996 law. So one of the main patch-up jobs in the new law under the Trump administration was to superficially invoke the interstate commerce clause as a way of trying to restore constitutionality to the law. So he avoided confronting the equal protection issue at the federal level, but he really just passed it down to the states, because if ritual nicking of the vulva for religious reasons in a medicalized fashion is a physical assault, then presumably a much more severe surgical intervention, namely removal of the entire penile prepuce for the same reasons within the same families, is also a criminal assault. But that is now an unresolved issue in American jurisprudence, and there are some other countries which are similarly grappling with this very thorny legal issue. Nevertheless, Judge Friedman was aware of the equal protection problem. He said, as laudable as the prohibition of a particular type of abuse, as he called it, again, sensitive to the language here, of girls may be, it does not logically further the goal of protecting children on a non-discriminatory basis. So typically, we don't write laws that are sex-specific. But the Female Genital Mutilation Act has it right in the title there. It only talks about the genitals of females. And as I'll discuss, it doesn't clarify whether that includes females with intersex traits or congenital variations of sex characteristics who seem to have been left out of the protections that are allegedly advanced by that type of legislation. So I'll step further back now and explain that this problem in the law goes back at least 25 years. One example of this is the work of Dina Davis, who's a very prominent American bioethicist and legal scholar. And she points out that, going back to 2001 when this article was published, federal and state laws that criminalize genital alterations on some female minors, namely the law is applied only in the case of minority immigrant groups, it's not applied to labiaplasties, are so broad that they cover even procedures that are significantly less substantial than newborn male circumcision, which is commonly practiced in the United States. It's a routine birth custom in hospitals in every city. A complete laissez-faire attitude toward one practice, coupled with total criminalization of the other, has, she argues, troubling implications for the constitutional requirement of equal protection, because the law appears to protect little girls, but not little boys, from religious and culturally motivated surgery. Now, Dina Davis was a very forward-thinking bioethicist, but even in this 2001 article, she wasn't really thinking about the debates that are now arising around surgery for children with what are sometimes called intersex traits, sometimes called differences of sex development, sometimes called disorders of sex development in more medicalized discourses. So this is one example of a representation of relative insensitivity to androgen, the so-called Quigley scale. And what I want to show is not the specifics of the genital anatomy, which just shows that in one respect, regardless of one's chromosomes, the external morphology of the genitalia can range from stereotypically male to female. But the legal issue, which is that modifications of genitalia that appear stereotypically male and are associated with children who have been designated as male at birth, as long as it's considered to be a circumcision, whether it's medically necessary or not, and regardless of the reason that the parents give, they don't have to give a reason, it's considered legal for a doctor to perform the removal of about a third of the skin system of the penis. On the other hand, with respect to genitalia that's considered stereotypically female, and particularly when it's associated with a child who's been assigned or designated female at birth, modification of the genitalia, at least for some groups, is considered a criminal offense, such that, as I mentioned, even pricking of the genitalia is considered to be a very serious crime. And now with the 2021 FGM Act signed by Trump, pricking is explicitly mentioned as being a criminal act, even if carried out by a physician, even if done for religious reasons. And then, of course, you have more morphologically ambiguous genitalia, some cases that appear to be more clearly intersex on some descriptions. And here the law is now in tension. People aren't sure what the law is or what it should be, and there's contestation. There have been some bills proposed to try to ban what are characterized here as medically unnecessary surgeries on intersex children, but so far those bills have been struck down. But I want to again step back and focus really more on a conceptual issue, which is if you consider that the morphology of the genitalia can range from stereotypically male to stereotypically female, and that you have some cases where you have a clitoropenile organ that's ambiguous between being a clitoris and a penis, you have to ask yourself, at what point does a small penis, which is considered currently in American jurisprudence legal to cut for non-therapeutic reasons, become a large clitoris, which is considered in contemporary American jurisprudence to be illegal to cut or even to prick for non-therapeutic purposes. Okay, so now I hope to have laid out some of the broader conceptual concerns. In my final 2 or 3 minutes here, I want to bring us back to the current moment. So I mentioned this executive order protecting children from chemical and surgical mutilation. This is aimed at so-called gender-affirming surgery and hormonal care for transgender and gender-diverse youths. Strikingly, the executive order defines a child as anyone under the age of 19, so that includes actually transgender adults, the age of 18. And the language says that the blatant harm, so here there's an assumption of harm done to TGG children, cloaks itself in medical necessity. And so this focuses then on, again, another unresolved issue in contemporary surgical ethics, which is what precisely constitutes a medically necessary surgery. There are some notions that are employed by insurance companies in terms of what they're willing to reimburse. But as an ethical concept, when is something medically necessary, as opposed to, for example, medically advisable, medically justifiable? This notion of medical necessity is increasingly contested, and that's going to be important. Now, this law also doesn't specifically mention intersex surgeries, even though intersex so-called normalization surgeries for cosmetic purposes that are performed in the absence of a physical health need, at any rate, are actually physically quite similar to some of the surgeries that are prohibited for older trans youths, even though those are in those cases voluntary. Whereas in the case of intersex children in infancy, they won't be voluntary in those cases. And this notion of consent, I think, will also become important. So with some colleagues, I have a paper. I was hoping to be able to post the preprint today, but I'll post it after the talk. We've done a systematic review of all the laws that seek in the United States to prohibit gender-affirming medical care for transgender minors, in some cases young adults as well. And we note that all of them have an explicit exception for intersex surgeries that are comparable, carry similar risks, and so forth, have uncertain benefits, at least in terms of causally attributable benefits to the surgery over the long term. And strikingly, 4 of the states also have an explicit exemption for medically unnecessary penile circumcision. And I think that that's actually conceptually quite interesting because it suggests that there's something behind these laws that doesn't have to do with ethical consistency so much as it has to do with enforcing a form of bodily normality as that's currently conceived in gendered terms in the United States. So 14 bans mention that medical and surgical care is disallowed if it affects or removes a minor's so-called healthy, functional, and non-diseased body parts. So that, of course, applies to the case of penile circumcision, which removes the healthy, functional, and non-diseased penile prepuce. That's why the exception has to be put in a couple of those states. But as I alluded to earlier, it also includes labiaplasty, which removes healthy, functional, non-diseased labial tissues. And what's striking is that evidence from 2016 to 2019 strongly suggests that nearly 20% of labiaplasties in the United States are performed on girls younger than the age of 18. Now, there are debates about the conditions under which a labiaplasty could even, in principle, be considered medically necessary. Sometimes a diagnosis of labial hypertrophy will be made, which basically just means long labia, and there's no standardized criteria, and certainly no notion of when long labia is objectively pathological in some sense. So often what you have is essentially a cosmetic surgery being done to alleviate anxiety in young girls, anxiety that might itself be caused by problematic social factors rather than the sheer anatomy of their genitalia. And again, if it's medically unnecessary, this should constitute FGM on the current law, but it's not applied that way because labiaplasty is seen as a Western cultural practice that's seen as relatively acceptable in the same way that male circumcision is seen as acceptable, whether or not it lines up with existing definitions. So here's my final slide here. What you find under the current regime is that voluntary and at least plausibly medically necessary hormones and surgery for transgender youths, some of them being defined as children, even in the case of adults, are considered impermissible, at least according to the Trump regime. On the other hand, quite similar, technically similar interventions that are non-voluntary and plausibly not medically necessary are considered permissible in the case of children with intersex traits. Non-voluntary, not medically necessary penile circumcision is also considered permissible. And then voluntary, but probably not medically necessary labiaplasty is allowed. But voluntary or non-voluntary, it doesn't matter. Not medically necessary pricking of the vulva for religious reasons among a minority Muslim community is considered a federal crime with very serious penalties, including having one's children taken away from one. So this seems like a highly gerrymandered situation, and I'll just try to suggest an explanation for it. So here's my explanation. Gender-affirming procedures, according to this view, are considered suspect because they alter a person's body to align with a gender category other than the one presumed at birth, which is inimical to the conservative view of gender. Males are expected to identify as boys and men, females as girls and women, and any other relationship between sex and gender violates traditional gender norms. By contrast, even genital operations that are neither medically necessary nor consensual are approved in this view if they preserve the status quo of what's considered normal for boys and girls. So this includes removing signs of sexual ambiguity in children with intersex traits, reshaping girls' vulvas through labiaplasty to make them more feminine and petite, which is consistent with gender norms, banning foreign practices like ritual nicking, even if it's much less invasive than labiaplasty, and altering infants' penises with circumcision to match the cultural norms for children who are categorized as male at birth. I think an alternative future for law and policy is going to be to shift from the x-axis here, which is determinations as to whether the child has stereotypically masculinized or feminized genitalia as the basis for whether it's permissible to perform a medically unnecessary surgery, to the y-axis, where we ask, is the person able to participate meaningfully in the decision-making about their own body? And if we adopt that standard, we might find that what's considered acceptable or unacceptable would be very different to what we find today. So I'll wrap up there and thank you for your time.
Great. That was a very interesting talk, Brian. Thank you very much. I think we're now going to proceed to the open, or not open, but at least ask the panel to respond to some of these questions that have been submitted. It was perhaps Rashi, but others could also comment on the slide that you showed about the cost effectiveness of surgical treatment, and the example being congenital heart disease versus malaria treatment. I wonder if you could expand on that a bit more. What do you think that considerations might be? Way to think about congenital heart disease treatment is not only to think about the individual patient, but what does the presence of such a program add to the overall medical sophistication and expertise throughout that medical center, whether it's treating newborn infants with prematurity or other kinds of sort of abnormal pathophysiology type disorders, particularly involving the cardiovascular and pulmonary systems in that institution. In other words, is there a knock-on or spin-off effect of having an investment in a relatively high resource type of activity?
Yeah, so I think that exactly what you're saying, I think applies more broadly too. So, I use congenital heart disease and malaria as two almost extremes of an example. But I think one of the things that the Lancet Commission talks about a lot, and one of the things I thought about a lot, is the idea of a bellwether procedure. So what you're saying about what are the knock-on effects, or what are the additional benefits of having a program that can manage such complex children? What are the benefits that are collateral almost? And I think the three bellwether procedures that the Lancet Commission identified were a C-section, a laparotomy, and an X-fix, so external fixation of a fracture. And one of the, what they kind of the suggestion is that if there is a health center that's able to do those three things, if they're able to do a laparotomy, do a C-section, and do an external fixation of a fracture, then you can probably do most things. Most basic things. And that's not the same as saying you can do congenital heart surgery, and so I think that's another kind of spin on it, but it's the same concept that if you invest in the infrastructure that is required to be able to do an exploratory laparotomy, or to do a C-section, or to manage an orthopedic injury, then you probably are able to you can do an appendectomy, you can do a gallbladder surgery, you can do a hernia repair, you can do, whatever else, so there's a lot of the basic kind of basic surgical procedures. And this also goes to, there's a whole other publication called the Disease Control Priorities Network, and there's 3 versions of that. The most recent is DCP3, and that was, I think, from around the same time as the Lancet Commission in 2014, 2015. And the DCP3 tried to identify 43 essential surgical procedures, is how they called it. And that was kind of along the same lines of like, these are the things that we think are the essential things that a surgical health system should be able to do. Congenital heart surgery was not one of those 43. But I think it speaks to the same concept of like, what are the things that we think about in how a health system that can perform surgery or can adequately manage surgical patients, what else can they do? And I think, thinking non-surgically, if you have an anesthesiologist, you have someone who can manage pain and manage sedation for other types of procedures, sedation and then like, if you have to have really good nursing care and perioperative care. And so what else does that benefit bring to managing other patients? And so I think one of the big arguments for development in surgical health systems is that there are these wider effects, like you mentioned, in that they can kind of up-level the whole healthcare system, even for non-surgical problems.
Great, thank you. Maybe I'll put this question out for all the panelists, which was raised early on in discussions, and that is, what does everyone think that the withdrawal of the U.S. from the World Health Organization will have on global healthcare outcomes? So maybe I'll ask each of you in turn to sort of weigh in on that question.
Okay, I guess I'll go first.
Yeah, why don't you go? We'll do it in order of presentation. How about that?
That means that Brian gets to just put the cherry on top. So
there you go.
Yeah. I don't know. It's obviously it's a very fraught question. It's a very tough time. It's very confusing. It's kind of, we've used the word unprecedented too many times for it to be novel anymore. But honestly, I think we can think of it as an opportunity. When we think about colonialism and neocolonialism in healthcare and in global health, which is something that I alluded to in my talk, one of the things we think about is who holds the purse strings, right? And who is the one, who are the people making the policies. And if the US, who is a huge funder of the WHO, pulls out, yes, there's no money, which is bad. But there's also an opportunity there for like the BRICS countries or other coalitions to come in and really take over in terms of setting priorities and the the agenda for the next few years. And I think while it is a bad decision, in my opinion, to pull out of the WHO for the US, I think that each move is a different opportunity for a new world order. So that's my optimistic response to that question.
Yeah, so thank you, Rashi. I think I'm also optimistic, but perhaps not as optimistic as you. I think two things. One, that it's actually a missed opportunity for the US itself, and that it is a missed opportunity for the rest of the world. So the concept of Ubuntu, as it were, that we are in this together, is kind of lost. And there's there are trust issues, misgivings now, with a lot of other countries within the framework of the WHO and the US on account of this. And I think that once trust has been lost, then it does take a lot. But how does the world get so dependent on one country, right? So those are the questions we need to ask. And that's what I look at as an opportunity, that people are being forced to think creatively in terms of funding for the WHO, yes, for many other things, and to kind of start investing and putting their resources, especially governments, putting their resources where the needs are. I think that because this kind of dependence has been there for a long time, the effects are going to be unprecedented is still the word, Rashi. The effects are going to be unprecedented, but eventually, things will settle. It may not be the same, but people are going to start taking responsibility for themselves. So that's my my cautious optimism that yes, this is an opportunity, and the world will move forward eventually. Over.
I have to
Brian?
say, I agree word to the word with what my fellow panelists have said, so I don't have much to add other than that sometimes there's genuine helping, and then sometimes there's sort of coercive or contingent helping, where you get the money if you subscribe to American policy priorities, for example. And so what you often find is that the person who holds the purse strings also holds the power, and they are able to shape local priorities in ways that are not necessarily coming from the grassroots in terms of what are the needs and priorities of the individual communities. A lot of it is really top down, and there are numerous policies that have this character to them that have come through the WHO due to US influence.
Yeah, I think that raises the sort of another term that we heard about to some extent, which was colonialism. And I suppose, as you correctly point out, that the people who provide the money get to set the priorities, as I think is well described. But there were a few questions that were raised about how important a factor is that colonialism is versus what the local governmental forms are, particularly in areas where there are dictatorships or other I will use the questioner's words, tyrannical forms of government. And what role, relatively speaking, do you think these two forces, this colonialism force that we've just discussed a bit, is the problem within country and its governmental form? So perhaps, Barnabas, I would ask you to start with that question, and maybe we'll let the others comment as well.
I think that's a very excellent question. And we need to realize that both have played major roles, but in different, very interconnected ways. Just think about them as kind of structural layers rather than mutually exclusive causes. I think that sometimes we try and separate these things as mutually exclusive causes. So if you really look at history, you find that colonial systems extracted resources. Coloniality still does the same thing: people, materials, knowledge. It's about the extractive thing. Without building local health systems, they built urban-centric health systems, elite-oriented hospitals, that were at specific places for colonial administrators, not universal health coverage, support. They suppressed indigenous knowledge. That paper that Rashi shared talks about some of these thoughts imposed different values on medical education. There are two very interesting papers that talk about the history of medical education in Africa, surgical education specifically, that talks to these things. So what's the legacy of this today? We've got weak rural infrastructure. We're relying on external training and certification. There's dependency on imported equipment, drugs, and things like that. And underinvestment in surgical health systems, even post-independence. So they're inherited systems that were never meant to serve people, right? And then look at what happened on top of that: tyrannical, corrupt governments. It's more like a contemporary barrier, but we're seeing underfunding of healthcare, diversion of funds from public goods, the corruption that is being seen, suppressing of medical autonomy and things like that, and violence, instability, and so brain drain, like we talked about, hospitals in decay and all that. So what are we looking at the two? We should be careful about a false binary, or it's more like a feedback loop. Colonialism produced fragile systems. It was replaced by fragile post-colonial governance. And then there are all sorts of, so we can say the colonial past laid the cracks, and then tyranny widened them. So we must kind of resist the urge to isolate the causes like that, and look at it as colonialism building a scaffolding for exclusion, and then tyrannical governments sustaining it. So we have to address both the past and the present issues. And again, don't ask me, we don't have all the answers. But I think that we need to think about this as a layered, multi-layered issue. So if you're looking at the concept of structural violence, you keep tracing it back, you get to a point. But this is my My sense within this that everything has a role to play. Low-income countries, high-income countries that colonized previous, everybody has a role to play because there are multiple things that go into this pot of soup. Over. Rashi.
I have
Okay, Brian or Rashi, other comments?
mic drop from Dr. Alayande.
I agree.
Okay, great. Let's get back a little bit to the brain drain question. And there were a few questions that result around what I think is sort of a ethical tension, if you will, between the rights of the individuals, that is the healthcare providers, to choose themselves where they want to go and what they want to do, and versus the in-country patients' rights to healthcare. And any thoughts about how to help address those two potentially conflicting principles? Maybe I'll ask Dr. Alayande to start and then others to weigh in.
Honestly, I know there are no easy answers, right? Because if you look at the genuineness of an individual who is in a situation where you see the country has poor health outcomes, you're looking at outcomes for the nation, and then you're looking at yourself and your family, and you must eat, and you need safety and security, so that conflict, and again, this is my thoughts on the matter, that I think that that's a good place to live if you are in this context, right? Living in that conflict, such that even if you decide to emigrate, you're still thinking about the outcomes for the country, and you're finding ways to circulate, to circulate literally, brain circulation, to impact and have projects and think about what you can do one way or the other back in those countries. So I think that eventually what wins out is a lot of the background of the individual, the moral dimensions of person looking at it this way or the other, whether or not this person has communities that can support them to stay or communities that are encouraging them to leave. So no easy answers really. There's a proverb in my context that says, man must work, right? You have to eat to stay alive, to be able to do certain work. So many people will prioritize, let me be okay out of this system. There's so much going on. I can't enjoy my space. There's mental health issues, etc. So the structural violence is forcing me out. So I need to leave. But when they leave, being in that tension, I think is a good thing, because it kind of guides you to be able to put back something into the system that one has left. Over.
Okay, Brian or Rashi, other comments in this regard? Guess not. Okay, not seeing any. Just to follow up on that a little bit, I know that certainly in this country, the US, there are some government programs where in exchange for government support, you are required to do service, if you will, in certain underserved areas is one thing. And I will reflect back on my own experience where, most everybody when I was in medical school, which is now quite a long time ago, was subject to military draft. And so by the time I finished my surgical training, which was many years after I graduated from medical school, I still owed, time to the military, which turned out to be a good experience for me, even though it delayed the time when I had what some might call a real job. But I think I actually gained a lot from that experience. But I wonder what the thoughts are about whether or not a similar sort of, contract almost, you get this benefit, you get the education and all of those other things. And then in exchange, you're committed and obligated to, to give back, if you will, in a form of service. What do people think about that?
I'm happy to say something just to relieve Dr. Alayande from having to answer all these questions. One distinction that's sometimes drawn in relational ethics is between communal relationships and transactional relationships. And this tracks a little bit the distinction you were drawing, Barnabas, between utilitarian considerations and deontological ones. Some deontological considerations concern duties we have to particular others in our lives. And so once you introduce the notion of a contract, it's just interesting that you then bringing in the logic of a tit for tat exchange. You get this because of this, and that's what you get in response. And, there are certainly times and places that are appropriate for contractual obligations of that tit for tat sort. But, a lot of this Ubuntu ethic that you also refer to is really more on the communitarian model, which has to do with help according to need and according to one's ability, and looking out for relational and social obligations, irrespective of these types of contractual and tit for tat concerns. So I'm just flagging that there may be some tension there. I don't know how to resolve it, but that's what comes to mind given my work in relational ethics.
Yeah, I would agree with that a lot. I think that there's, this is something that I was thinking about doing a project on, Barnabas, you might remember. I wanted to think about and explore what people's motivations were for doing global surgery and like what it means to them. And I think it's just a very basic, simple question. It's like, why are you motivated to do this work? And I think for a lot of people, it's the same thing as why do you want to be a doctor? Everyone's like, oh, I want to help people. But then you see that there's real life problems associated with working a bajillion hours a day and away from your family and all these things. And you kind of have to cut back and say like, okay, well, I have to do what's right for me and my people that I immediately take care of. And that tension, I think, exists in general in medicine, but then to add that extra layer of is what's right for me to go somewhere else, and what's my obligation to my community and what's my obligation to myself. That tension exists, I think, in many things, but then to add that extra layer that you're talking about with in terms of like the structural violence component of it, I think it's just it's an added layer of stress. So I think it exists, and then it exists worse.
Just to speak to some specific examples, Dr. Meyer, that in Rwanda, for instance, once people finish a residency, they have to stay for 4 years, right? And so that's also on the East African divide. In Nigeria, when people finish residencies, in most parts of West Africa, you don't need to stay. There's no obligation. Even the medical school where I teach now, the students get like a full free ride, but they have, regardless of what country they're coming from, we can only take them after they have made agreements with their governments that they would work within a rural context, a place where there is need, for 5 years before they come in. Now, some people can pay back, like pay off, and say, hey, they don't need to. But we try to avoid calling it a contract. It was called Umusanzu, which is, again, within the Ubuntu framework, an agreement, a way of you giving back from the time you get into school. How are you going to give back what you have received, versus some other context where this is like an actual signed public service agreement. So there are tensions there. For instance, the community in certain countries have pushed back against this and said, hey, we don't want this. I mean, this is a violation of my rights, more or less. But I think that brain drain sits at that intersection between individual freedom, collective justice, and people have the right to pursue their dreams abroad, right? But their patients also have the right to live. And the challenge would be to build systems where these rights don't collide, but rather they collaborate. And so that's the tough bit with contracts, with whatever, if it can be built in such a way that they collaborate rather than collide. I think that this may be one way to go, but it's just not the same. Again, I had the same opportunity with Dr. Mayer. There's a 1-year compulsory paramilitary service that I did after school, not related to medical school, but everybody who finishes under the age of 30, you have to serve that way. And the essence was to integrate. So, and everybody does it. If you want a political appointment, you have to. If you need to work in certain places, you have to. But there also cries to, is this okay? Is this a violation of my rights? Is this something that I should do? Is this something I don't need to do because I will emigrate anyway? So again, as I've said, no easy answers, but one pattern to think about would be to do this in such a way that the rights of individuals, the right of the patient to live, and then the capacity to pursue people's dreams don't collide, but they collaborate. Over.
Any other comments, Rashi or Ryan? No. So there's a question for you, Rashi, about there's a specific country that's mentioned that I think maybe I'll leave out, but what about a country that has increasing corruption in such a way that human rights do not seem to exist? There's nothing going on in health policy in terms of advances or economic gain for any political party or politician. What, in a more general sense, what do you think about? How do you think about the impact that corruption produces in health systems, and still be consistent with the 2030 goals that you described?
I'm not
just a straightforward softball question, right?
Yeah, right. Yeah, I don't know. I mean, avoiding corruption is not an answer, right? Because there's reasons, as Barnabas was saying before, it's not a binary of colonialism and local tyranny or corruption or whatever. And it's the same thing here, I think. I think it's kind of I don't know if Brian or Barnabas has any other thoughts, but I would say it's the same concept. There's pressure from the US, the WHO, the UN, the global North, the stock market, whatever. There's pressures to achieve certain outcomes. And if the way that a governmental body is set upon achieving those is through corrupt measures, that my bias is to say that that's probably been put in place by histories of the way that that government has been put into power, whether that's destabilizing forces from external colonialism and extraction, whether it's the way that that government came to power. I mean, I don't know that there's a way to separate out how to achieve sustainable development goals, aside from like targeting corruption. I don't know if that answers the question, but I will defer to my co-panelists.
Any other comments?
I wish I had more expertise on the politics of corruption, but alas, it's totally outside my wheelhouse. So I'll have to remain silent on that, about which I cannot.
Okay. So maybe following up on that, something that you mentioned before, Rashi, is about the global North and the global South. And one of the questions from the audience was, what mechanisms exist? What can we do to foster the dialogue on justice and equity between the global North and the global South?
I love this question because it's something I think about quite a bit. I think actually probably my co-panelists also think about this quite a bit. We're all, Barnabas is the one who did have a positionality slide, but this is something that we learned about positionality in our work together. And I think that's something that troubles me most of the time is, who am I? Like, that is what I think about a lot. Who am I to say? And when I started doing my fellowship at the program in global surgery and social change, I was super uncomfortable because I was assigned, to work in a certain region of the world with people there who then are like, well, what do you think? You're the Harvard fellow. And that was so awkward for me because I they're asking me for my opinion and giving me power that was undue only because of the institution and the country from which I am a member, right? So that is super awkward. And also, I think it should be awkward, because if you're not worried about that, then you need to get out of it, get out of that space. So I guess in a word, to quote Paul Farmer, in a word, partnerships, right? Partnerships are the key, in my opinion, and developing true, long-lasting relationships with people is the way to learn who they are and where they come from and what's important to them, and really bringing them into your space. The buzzword of sponsorship, rather than just mentorship, giving up your space for someone else, putting yourself at the back burner, giving your spot on a panel to someone else, or giving your first authorship on a paper to someone, not giving them, but helping them get there, teaching them how to write, teaching them how to conduct the project, being a back burner for them to ask questions of, but not giving them, not gift authorship, but teaching them how to be the person in charge of the project. And it happens very slowly, and that can be frustrating for especially a surgical trainee who's used to getting things done. But this process takes a long time, because it takes a while to get to know a person and then get to know a place. And I still feel that tension, but I think as I become more my relationships grow longer and more deep, then I kind of settle into this fact that it doesn't really matter where I come from, as long as I'm using my power to leverage others. I don't know if that answers the question, but I will defer to you guys as well.
I'm so happy that you mentioned the issue of relationships, which I think is key. And I guess I would just add some window dressing to what you've already said, which is, I think, for me, when I work in ethics, particularly cross-cultural ethics, I'm interested in attitudes of respect and humility, and also looking out for hypocrisy. I think when it comes to defining human rights violations, for example, it's one of those things that the US also gets to set the rules. It decides that human rights violations are what other people do, not what we do in the United States. And so I think if you start with, I have a saying from my evangelical Christian upbringing, which is you have to take the plank out of your own eye before you start looking at the mote in the other person's eye. And so I think when I'm thinking of positionality, I think of US influence on global policymaking is often leading with looking at the mote in everyone else's eye and not addressing the plank in their own eye in terms of human rights violations in the United States or policy failures in the United States or what have you. So respect, humility, and non-hypocrisy, I think, are key ethical features of the relationships that you describe, Rashi.
Very good.
Yeah.
Go ahead, Barnabas.
Yeah, I wanted to jump in, just thinking about certain frameworks that we can use. There's a beautiful scoping review by Monet et al., which I coined as like Monet principles, that if we're dealing low middle income country, global south, global north, etc., we need to actually think in such a way that there's no giver, taker, there's no, like, it should be win-win. And so we're talking mutual benefit for everybody there, setting the agenda together, not setting the agenda somewhere and then bringing it to the other context. Either way, then we should think principles of equity, and then accountability mutually, and then build capacity. So if there's any connection between the global north, global south, that leaning in that Rashi describes, or is it leaning out, that being willing to give people that space, it actually has to do with the patience of building their capacity to do something. Not that, oh, these guys just can't do it. Really taking your time to hold somebody's hand and then to walk with them down the line. And I think that it's not about getting everything to be perfect. It's about making progress. So the way we were in our relationship last year should not be the same place we are now. We should be moving closer and closer towards equity, and it should be visible. That progress should be seen by all. And then there's this concept of humble confrontation, right? Constructive confrontation. We should permit that, and then that humility of saying, "Oh, I'm sorry. This is wrong. I did this wrong. I'm sorry." And then moving forward together has to really be embedded within our practice, across board. So again, lots of thoughts around this, but I think that that's one way to go. We should have frameworks with which we deal with each other across these divides. We should have real clarity and not just go into these relationships, global south, global north, without, clarity of basic frameworks. Over.
Yeah, I guess I will just share my own personal experience to some extent with this, where we back to the congenital heart disease theme, but there were some projects that were organized through an entity called Project Hope, which everyone may remember from decades ago, with a hospital ship that went around to different places to offer care. But in a somewhat more recent era, they were involved in trying to bring various kinds of advanced therapies into countries that asked for help. And I think that was really a good model, because I participated in at least one of those, and some of my colleagues in our institution participated in other efforts in different places. But I think that countries asking for help, they can find us as partners to help them do that. Actually, there was a lot of federal funding, U.S. government funding, that was behind all of that effort. There were, I think it was quite effective, and in several locations, but it was always a partnership. We would go in and help them do the kinds of surgery that maybe they didn't have much experience with, but it was all with the idea of building the local capability, and not just going to a center, operating for a week and take care of 10 children or something like that, and then leaving, and you haven't left anything sustainable for the future. And in fact, these programs that I was describing were actually a major part of the mission, was to actually build the local capability. And I think that's really a important distinction. We hear a lot of things about medical missions, but I'm not sure that they are all, as effective in helping build the local capacity as they should be. It would be my argument. And certainly one of my partners right now has had a commitment for many years to work and build the capability in Ghana. And I think it's really been quite effective. And I think that is an important distinction between a medical mission, where you go for a short time, and actually going with the idea of building capacity and capability in wherever it is that you're going to help. Okay, I think we're getting close to the end. I promised Dr. Hanto a few minutes at the end to summarize and perhaps provide a little bit more information about the upcoming session a week from today. So, Dr. Hanto, you're up.
Thank you, John. I would like to thank our presenters tonight, Dr. Jhunjhunwala, Dr. Alayande, and Dr. Earp, and our moderator, Dr. Meyer, for their outstanding presentation and discussion of several critical issues in delivery of global surgical care. I would also like to thank all of you who listened tonight and asked questions of our panel. Would also like to thank Dr. Rebecca Brandell, the Director of the Center for Bioethics, Dr. Wes Boyd, Director of Education in the Center for Bioethics, and Dr. Jonathan Marin, Director of Clinical Ethics in the Center for Bioethics, for their unfailing support of this conference. Finally, I would like to thank Jay Cowan, Victoria Cunningham, Courtney Lombard, Leslie Nicolini, Melissa Nozel, and Noah Venuti for their organizational, marketing, technical, graphic, and regulatory support of this conference. On behalf of the Surgical Ethics Working Group, we thank you for attending. We hope that you've learned and enjoyed tonight's presentation, and we hope that there has been information that you will be able to use as you address bioethical issues in the future. We look forward to seeing you in the last session on Monday, April 28th, when our topic will be implementation of artificial intelligence in surgery, ethical considerations. Thank you again, and good night.